I'm going to talk about a survey that I did about oral health behaviours for people with inhibitors. And I'm interested in this in a wider piece of research that I'm doing, which is about the new definition of oral health. And we know that oral health is much more than just good teeth. We know that good oral health is a really important part of general health. We know that poor oral health often means really poor related quality of life through pain, through stigma, through inflammation. And we know that it's multifactorial. We know that what generates oral disease is not only what happens in the mouth, but it's multifaceted. It's got driving determinants, it's got moderating factors, but there's lots of things external that govern whether people have good oral health. And the definition nowadays is much wider than it used to be. It includes the ability to speak, to smile, to smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. It's a really fundamental component of health and physical and mental well-being, and it reflects the conditions in which people live. But it's also influenced by their experiences, their perceptions, their expectations, and their ability to adapt to the circumstances in which they live. So I'm in the middle of developing the core sets for oral health for the ICF, the International Classification of Functioning. This is used in research and healthcare and provides lists of specific health conditions, body functions, body structures, activities and participations, and environmental factors that are relevant for oral health, that impact on oral health. The social determinants, but not only the social determinants, but the psychological and other beliefs. The reason that I'm doing this is because we want to see where they overlap with other areas of health. We're always looking at common risks, common ways to promote health, where health professionals can work together. So we wanted to find out what the real drivers of oral health are. To get these involves a lot. It's a big review of the literature, lots of interdisciplinary surveys, focus groups, and empirical studies. And I've been working on this for 6 years to come up with the core definitive sets of what causes or what are the predeterminants of oral health. And because I recognized that this would help us identify in hemophilia what was happening, we did a big data collection of people with a lot of physical disabilities across 4 centres, not only hemophilia, but lots of different physical disabilities, to look at what were the drivers for poor oral health. We looked at body functions, body structures, environmental and personal factors. And we realized that one of the big core predictors of poor oral health was people's ability to acquire, keep, and terminate a job. So somebody who's not able to work is less likely to be able to afford. So they would be put in a high risk for developing oral disease category. Those people who are not in intimate relationships, they haven't got partners to kind of mind them, or they might be isolated. Those people who have low mood and are unable to handle stress, and critically have problems carrying out a daily routine for whatever reason. Doesn't matter, but if something impacts on an ability to carry on a routine, it's going to mean that their oral health is at risk. And economic self-sufficiency. So somebody doesn't need to be working if they've got a nice pension or they've got a rich partner, then it means that they're actually they're not going to be so. We looked at those items that really also embody functions. And we got it down to some really important ones. And this is where it became interesting for me, because one of the top predictors was energy and drive, mobility of joints, and muscle power function was one of the biggest predictors of all of having very poor oral health. So I decided to do a quick pilot study of people with inhibitors, because what I realized was that many of those determinants meant that they were at high risk of oral disease, and the very people who we want to avoid surgery and we want to avoid actually developing oral health problems were probably the highest risk in the population that we know. So I wanted to investigate just to see if the behaviours of people could overcome those risks, because dental disease is 100% preventable, and we know the risk factors. Gum disease is preventable, and we know the risk factors. So if people are identified as having high risk and they practice the right behaviours, they won't develop dental disease. They won't need extractions. They won't be having the problems that lead to poor oral health. So I needed a pilot study, and I did a convenience sample of people with inhibitors at a European summit meeting. And I used several very validated disease indicators and patient-reported indicators out of there. Now, these are all validated. We know they're all reliable. However, this is a patient-reported study. This was not me looking in mouths, okay? This was me looking at whether I perhaps need to really go forward in the future and look at the mouth. So we had 25 people attending, and small sample, but that's a lot of people with inhibitors altogether. And 21 males completed a questionnaire about their oral health beliefs and behaviours. They were from 15 countries, and their mean age was 34. They were quite young. Age range was from 18 to 73. I think that is the oldest person with hemophilia, with inhibitors that was there. And the limitations of this study was this is not a representative sample. This was a group of health champions. They were representing their countries. They're top of their game. They are, are not going to be your typical people with inhibitors. So I didn't know whether I'd get a particularly useful result. And it's a small sample, but they were well over from Europe. So I asked them how would they rate their oral health using Locker's global self-rating of oral health. Very valid, simple question. And actually, about 45% said it was good or very good. More people said it was fair, bad, or very bad, but quite a good proportion thought their oral health was good. But interestingly, when I started to ask, do you think if you went to the dentist tomorrow, would you need care? Now, this is a very reliable question because it's been validated as pretty good, that people generally know the state of their mouths. So 68% said yes if they went, despite saying their health was good, if they went to the dentist tomorrow, they'd need treatment, ranging from 80% said their teeth needed cleaning, 40%, that's not needed dental extractions, 50% needed fillings, some people needed root canal, another 40% needed a deep cleaning. So what we're seeing there is a high treatment need in a very health literate, top of their game population. So it's not surprising that we saw problems in this group, because 55 of them were smokers, and we know that smoking is a big risk for the development of periodontal disease, oral cancer too. We know that half of them took sugar in their coffee or tea. A lot of them didn't drink alcohol, but drank a lot of coffee or tea. So we knew that one of the big risk factors for holes is sugar, because the mouth is designed to be able to protect itself from sugar if it's taken not too regularly. But for somebody who's having sugar in a coffee or a tea, or having sugar any time within a 3-hour interval, the mouth and the teeth don't have time to repair themselves. So that's when the cavities start to develop. So 47% took sugar in coffee and tea, and that's why it's difficult. 2 things are a problem: sugary fizzy drinks and sugar and tea. And interestingly, about half hadn't seen a dentist in the last 2 years. So what we've got here is the population at the highest risk of disease, who actually, if they develop disease, are going to need quite difficult surgical protocols, who aren't going to the dentist, or certainly not going, as is recommended, to have your teeth checked at least once a year. What happens if you have your teeth checked once a year is that things can't get into real trouble. It takes more than a year for problems to develop. So if we see people every year, we can do the new fashionable minimally invasive dentistry. We can paint potions and lotions on the teeth. We can prevent the fillings and things from developing. But here, sadly, half hadn't seen a dentist in the last 2 years. And the reasons were things like, I can't see, my eyesight's going. I've had bad experience with dentists. I'm scared of the dentist. I can't afford to go to the dentist. I'm too busy, I have difficulty getting to the dentist. So what we're saying here is there's some barriers there for patients. About 75% believe there were things about their dental treatment that could be better. We didn't go into that, but really, really important to me here was the respondents were ambivalent to the idea that dental treatment could reduce their bleeding gums. We've got here, this is the locus of control and beliefs and behaviours questionnaire. And it asks about how concerned they were, how well they understood the cause, how much do you think dental treatment can help bleeding gums? And 75% believed that that the dentist couldn't do anything to help them with their bleeding gums. Now that's going to be quite a hard nut to crack to go forward. Now, this is where it got interesting. Remember, this was our health literate team. More than 70% of the people in the sample's gums bled for more than 2 minutes following brushing. That's enough to impact on people not bothering to brush, because 2 minutes is quite a long time. 20% bled for more than 10 minutes following brushing their teeth. And that indicates advanced gum disease, because healthy gums don't bleed. And 60% of those people reported not being able to brush or floss their teeth properly through joint issues. And this is really interesting, because this is probably what's generating. Remember what we said at the beginning, that the biggest generator for poor oral health is going to be not be able to brush their teeth. And the sad thing is that in dentistry, we have so many things that help people brush their teeth. So if I'm talking to a conference where people have rheumatoid arthritis, for example, they're all kitted out with special electric toothbrushes. They have toothbrushing handles that help them. But in this survey of very health literate, probably fairly well off people, because they could travel to that conference, only one, for example, used something like an electric toothbrush to help them, or, before we even started going to extended handles, all the fantastic kit that's out there to help people brush their teeth. So we started to look at statistics, because what I've learned going forward in this job is that surveys and all these type of things, and doctors and questions, there's only limited time. So how can we predict whether patients are going to have problems with their mouths? Well, this is a small sample, so we can only look for predictors and probabilities. And the way to measure this is by using Bayesian method statistics, because this generates hypotheses based on probabilities observing one impact if another is present or absent. This can identify common risks. So what I would say is that of the people that we saw with inhibitors, 17 out of 21 had affected target joints, with the knee, ankle, and elbow being the most commonly affected. The Bayesian correlation coefficient showed that really high, credible, positive correlations between limited movement of the elbow and incidence of severe gum bleeding, and even higher with reports of spontaneous gum bleeding. So I think what I can say from this is the incidence of target elbow and shoulder joints is strongly associated with spontaneous, severe gum bleeding. But despite expressed difficulty in brushing or flossing because of that difficulties, in this highly educated group, no hygiene aids were used to take account of those joint restrictions. What we also see is this often collected joint data. We know that joint scores are on all of the surveys, is a reliable predictor of poor oral health. If someone ticks restricted joint movement, we can almost definitely say oral health, and we need to get them on high-risk protocols at the dentist straight away. What I would say is that probably, if we're time limited, asking the simple question about how long gums take to stop bleeding needs investigating. I would like my next study to look at subjective versus objective. Does what patients tell me on a self-reported questionnaire actually equal what I would see in the mouth? Because we've got lots and lots of great indices to measure gum bleeding. What was particularly interesting for me was the fact that oral health-related quality of life tools, and we have these, they're a set of 14 questions asking people about the effect that oral health-related quality of life measures them. And what this showed was that these weren't impacted by people whose gums bled for a very long time. This is unusual. You'd think surely that affects people's lives, but the fact is, in common with so many other long-term conditions, we know that people with long-term pain conditions are incredibly stoic, that they have incredible coping skills, but importantly that this group of people didn't believe that there was anything that could be done about these gums. And we know that quality of life is about what people have and what they think they should have. And this tells me that this group expect their gums to bleed, sometimes from 10 minutes afterwards, for 10 minutes. So my conclusions are, hemophilia itself does not have any particular risk factors for oral health. However, poor oral health status was common in this group, and their beliefs and the lack of locus control and inevitability of gum bleeding was really common. What I found that despite being an at-risk group, dental attendance was ad hoc. That means that dental decay and dental disease is going to progress. We know that the predictor of poor oral health is the presence of the target elbow joint, followed by the shoulder joint. So I feel going forward that if we're looking for partners in identifying people who need to promote oral health with us, probably the physios will be the people to actually start probing people to go to the dentist, because they're obviously not coming to see us. We saw that from those behaviours. So I'd like to thank you very much.